Hi, and thank you for joining me on this chapter, Immunologic Emergencies. This class is being recorded during the 2020 COVID-19 pandemic. Please pay particular attention or strict attention during this presentation because you will still be responsible for the information on the regularly scheduled module test. Let's begin our discussion on immunological emergencies by talking about pathophysiology. Now, an allergic reaction is an exaggerated immune response to any substance. Now, it can be confusing. It's not caused directly by an outside stimulus, such as a bite or a sting, but rather it's caused by the body's immune system, which releases chemicals to combat the stimulus. Some patients may not know what is causing their allergic reaction, so you must be able to recognize the signs and symptoms and maintain a high index of suspicion. Keep in mind the allergic reaction that you are looking at the time of your patient contact may be caused by an allergen that the patient has encountered for the first time. By the way, an allergen is any substance that enters the body, is recognized by the immune system, and then causes an allergic reaction. It's also worth noting that people may develop an allergy over their lifetime. Some examples of this would be latex or some antibiotics. An allergic reaction may be mild and local, recognized by itching, redness, or tenderness, or it could be severe and systemic, a condition known as anaphylaxis. We'll delve into these two things a little further in the presentation. Anaphylaxis is an extreme, life-threatening allergic reaction. It involves multiple organ systems, and in severe cases can rapidly result in shock and death. What we're seeing here is an introduction of an antigen or an allergen onto a mast cell. Mast cells are certain cells found in connective tissue whose normal function we really don't know, but they're frequently injured during an allergic reaction. So when a mast cell is injured, it releases histamines into the tissue and blood. Now these chemicals cause the irritation, the swelling, the leakiness in the cells and the vessels. It can also cause the muscle spasms that lead to chest and throat tightening. So what we're seeing here is, first off, in A, we're looking at the honeybee that introduces the allergen or antigen into the body. The antigen's antibody reaction is at the surface of the mast cell. And in C, we see a release of mast cell chemical mediators. Now, specific antibodies react to the corresponding antigen. So chemical mediators exert their effects on the organs. So let's look at them specifically. When we look at the lungs during an allergic reaction or anaphylaxis, we have bronchospasm. What bronchospasm is a tightening down of the bronchial passageways. Now remember, these aren't just plastic pipes, they're dynamic. They constrict and dilate. In this case, the introduction of the chemical mediators from the mast cell will cause bronchoconstriction and spasm. It'll also cause, in the lungs, vasoconstriction. Let's look at the heart. With the heart, you'll have a decreased output and a decrease in coronary flow. So the heart isn't effectively feeding itself. The blood vessels will dilate and become leaky. Now keep in mind, when these things happen, especially with the heart and the blood, what do we expect the blood pressure to do? We expect the blood pressure to drop. The vessels are big, there's not enough fluid to fill them, the heart's not working at its maximum efficiency, so it's not working either. Now, we'll look at the skin too. So you'll see some urticaria, some edema. Now, we'll note in the upcoming slide that the urticaria, that the hives will start centrally, meaning probably in the area of the chest and the back. That's where we'll look at them initially. Plus, you can have some swelling or edema in the lips, around the eyes. Here we're looking at the common signs of anaphylaxis. Anaphylaxis, remember, is the severe allergic reaction. So you're seeing there in the top picture urticaria or hives. Again, hives will probably start more centrally. We'd look for them on the trunk, in the front and back, the ventral and the dorsal side of the trunk, and they would move their way outwards onto the arms and legs and up and along the neck and the face. Then there's angioedema. What you're seeing there in the bottom picture is the swelling of the patient's tongue. Again, in severe cases, this could cut off the airway. You may want to consider using like a nasopharyngeal airway early in this case. We'll also be looking for signs of respiratory distress. Now, we'll look for the patient using accessory muscles, but we'll also want to take our stethoscope and carefully listen for wheezing caused by that bronchial constriction. In the allergic reaction, especially anaphylaxis, the severe allergic reaction, patients can also experience hypotension due to vasodilation and increased capillary permeability. Now, again, what's happening is the vessels are dilating. Again, not enough fluid to fill them, and the blood pressure will drop. They may also have gastrointestinal dysfunctions like nausea, vomiting, and abdominal cramps. Now again, it's worth noting here, and I'll hope to remind you throughout the presentation, that when you have reactions in 2 or more of the body systems, even though the patient might not be having trouble breathing, they should probably still get epinephrine. So, with that in mind, if the patient is showing skin signs, hives, swelling, and gastrointestinal signs and symptoms, nausea, vomiting, they would get epinephrine just the same as the patient that would have the trouble breathing, the wheezing, and the closing up of the throat. Something to keep in mind. In these next few slides, we're going to be looking at some common allergens. Now, food allergens, mainly see them in shellfish, nuts, could be other things too. Strawberries is not an uncommon food allergy. But the symptoms may take more than 30 minutes to appear. Again, this is being absorbed into the intestinal tract. Something else to keep in mind, that unless the patient vomits, the allergen is still inside of them. So they can have an ongoing reaction. So your epinephrine may actually wear off and need to be redosed. Maybe not immediately, maybe not during your transport, but sometime during their hospital course. Now, medications, they can be ingested, but they can also be injected. And the reaction, especially in the injected medications, may be immediate and severe. Again, like the food, oral medications can take up to 30 minutes to appear. Plants are also one of the sources of allergens. Certainly year-round in the state of Washington, pollen is given off, as well as dust from inside. People stay inside a lot during the winter months here. So some of the things that we may be considering with plants are the dust, the pollens, ragweed, ryegrass, maple, and oak as we come into the springtime and down through the summer. Chemicals such as makeup, soap, and hair dye can cause allergic reaction. Latex is a particular concern to healthcare providers. We've pretty much have gone into using nitrile gloves. We try to keep latex out of all of our medical products. Insect bites and stings account for a large number of our anaphylactic and allergic reaction calls, especially in the spring and summer. envenomation is the process of an insect injecting its venom. Now, when insect venom is injected, it could lead to a localized, most commonly, a localized reaction. That's a bump, swelling, redness at the injection site. Or in people who are especially sensitive to insect venom, it could lead onto the systemic reaction of difficulty breathing, hives, swelling of the throat, gastrointestinal, like we've just discussed. Approximately 3% of adults and 1% of children are allergic to the venom of bees, wasps, and hornets, and insect stings account for at least 50 deaths in the United States each year. In half of these deaths, the victim has never experienced a reaction in prior stings. The stinging organ of most insects is a small, hollow spine projecting from the abdomen. Honeybees cannot withdraw their stinger. If the stinger is not removed, it can continue to inject venom for as long as 20 minutes. Wasps and hornets can sting multiple times. Let's kind of discuss this. Wasps and hornets have a spine that can actually go in and retract back up into the wasp or the hornet's abdomen. Now, in the lower right-hand corner there, you actually see where somebody is trying to pull a honeybee off. And you see that protrusion there. That's actually the bee's backside being pulled off. The stinger is still under the skin, and that bulbous area on top of the skin are the venom sacs. Once these are pulled out, those will actually continue to spasm, injecting venom into the patient. That's why in this case, if there's a stinger present, it's best to use a card to push away the venom instead of using tweezers. If you use tweezers, they'll actually squeeze those venom sacs and introduce more venom into the patient. Some ants, especially fire ants, can strike repeatedly. They have the same type of spine stinger as the wasp or the hornet, where it retracts back up into the abdomen. Signs and symptoms of an insect sting include sudden pain at the site, swelling, localized heat, meaning it's a little warm around the area, widespread urticaria, redness in light-skinned individuals, itching, and possibly a wheal, which is a raised, swollen, well-defined area on the skin. As long as these manifestations remain localized, they're not usually serious. Now, in the more severe allergic reaction caused by insect sting or anaphylaxis, the patient may experience, like we discussed before, the bronchospasms and the wheezing. Check their lung sounds. Chest tightness and coughing. Dyspnea, that feeling of not being able to catch their breath. They may become anxious. They may have gastrointestinal complaints, nausea. They may be vomiting, and they may suffer hypotension. Remember, any two areas or body systems that are affected warrant the use of epinephrine. And when in doubt, always call medical direction. Anaphylaxis caused by insect stings may cause the patient to go into respiratory failure. And if untreated, the anaphylactic reaction can result in a rapid decline to death. Always be ready to give epinephrine. Think of it early and be ready to perform bag valve ventilations or CPR. As with all calls, we want to start with scene size up and scene safety. We want to look at the patient's environment and look for any recent activity or indications of what may be the source of the allergic reaction. A respiratory problem reported by dispatch may be an allergic reaction, but until a field impression of an allergic reaction is firmly established, be mindful of other potential causes of respiratory distress. Traumatic injury may present secondary to a medical emergency. Follow standard precautions with a minimum of gloves and eye protection. If the patient has a productive cough, consider masking both the patient and yourself. Consider the need for additional resources, such as advanced life support. In your primary assessment, quickly identify and treat any immediate or potential life threats. ABC should be reassessed repeatedly throughout transport. Form a general impression. Allergic reactions may present as respiratory or cardiovascular distress in the form of shock. If the patient is anxious and in distress, immediately call for ALS backup if available. Look for a medical identification tag if the patient is found unresponsive or is unable to answer questions. Quickly assess for increased work of breathing. Dyspnea. Uses of accessory muscles, especially the sternocleidomastoidals, and also look for retractions. Look for head bobbing, an indication of difficulty breathing, along with tripod position and nasal flaring. And listen for abnormal breath sounds. Assist the patient to a comfortable position to help maximize ventilation. If signs of shock emerge, immediately place the patient in the supine position as tolerated. Even though it's not in vogue currently, a lot of pre-hospital providers like using the Trendelenburg position where the legs are raised. Initiate high-flow oxygen therapy or assist ventilations as necessary if needed. Constantly assess your patient's ventilation and assist when necessary. As we continue our primary assessment, we look at circulation. The patient may present with hypotension. Pay special attention to the blood pressure, but also assess for signs of hypoperfusion, delayed capillary refill, tachycardia, restlessness of the patient, nausea or vomiting, thirst, rapid shallow respirations, and treat for shock. Get them in proper position, make sure that they're warm. And the definitive treatment for anaphylactic shock is epinephrine. If anaphylaxis is suspected, or if a relatively mild allergic reaction appears to be worsening, immediately transport the patient. If the patient is calm and does not exhibit severe symptoms, Consider continuing your assessment, but err on the side of emergency training. As with all patients, we want to take a careful history. Investigate the chief complaint or history of present illness. Identify signs and symptoms. As we perform our history, we want to look for and identify signs and symptoms of an allergic reaction. In particular, shortness of breath, tightness in the chest, labored breathing, wheezing. Remember to take careful lung sounds. Watch for an increased pulse, red flushed skin, and in serious allergic reactions, we'll see a decrease in blood pressure. Watch for flushing of the skin, swelling around the face, neck. We also want to watch for cyanosis or pallor around the lips, and look for it in the fingertips also. Look for hives, urticaria, in the large areas of the body, including the dorsal and ventral trunk. Watch also for decreased mental status, gastrointestinal signs and symptoms, headache, and dizziness. Anxiousness is a much ignored sign of shock. Be aware, if the patient is anxious, they may be shocky. Use your sample history. If possible, ask questions involving, has any interventions already been completed? Some people may have used their own EpiPen. Make sure that you look at their EpiPen to make sure that's the right dose and that's within date. Also ask if they've had an allergic reaction in the past, and if they have, how severe had it been. Be alert to any statements regarding ingestion of food that might cause allergic reaction. Remember, those allergens stay into the gastrointestinal system and continue giving off the allergen throughout the gastrointestinal tract. Ask if the patient has any gastrointestinal complaints such as nausea or vomiting. During your secondary assessment, do a careful physical exam. If indicated, perform a rapid exam of the body from head to toe or conduct a physical examination focused on the areas of chief complaint. If the patient is unconscious or otherwise unable to communicate, remove clothing as necessary and look for the presence of bee stingers, signs of contact with chemicals, and other clues suggestive of a reaction. Look for a medical alert tag that could indicate a severe allergy. Auscultate for abnormal breath sounds and inspect the skin for swelling, rashes, or urticaria, hives. Make sure you take a good set of vital signs. Assess the baseline vital signs, including pulse, respiration rates, blood pressure, pupillary response, and oxygen saturation. If you're able to obtain a carbon dioxide reading entitled CO2, please go ahead and do that. Skin signs may be unreliable indicators of hypoperfusion, as they may vary widely or be hidden by rashes and swelling. Pulse oximetry can be a useful method to assess the patient's perfusion status. However, if the patient has peripheral shutdown due to hypoperfusion, shock, it may be difficult to get a pulse oximetry reading. Decision to apply oxygen should be based on airway patency, their work of breathing, and a normal lung sounds. Patients who are wheezing or having any extra work in ventilation should receive oxygen. It's really important to reassess. En route to the hospital, repeat a primary assessment, reassess the patient's vital signs, and repeat a focused physical examination of the affected body systems. If the patient is unstable, reassess every 5 minutes. If the patient is stable, reassess every 15. Watch for signs of shock and treat immediately if present. Keep in mind that with allergic reactions or anaphylactic reactions, these patients can change actually fairly quickly, so you must be alert at all times during transport for any changes in the patient's physiology. Treatment is determined by the severity of the allergic reaction. Mild allergic reactions may require only supportive care and monitoring. Anaphylaxis requires more aggressive treatment, including epinephrine and ventilatory support. Recheck your interventions. Even if the patient has experienced relief, transport to the emergency department is still warranted because the medication's effect will wear off and symptoms will return. Anaphylaxis and allergic reactions normally take a fairly long course of treatment in the emergency department. They may or may not be released in the same day. Careful documentation is necessary with all patients. Make sure you document signs and symptoms found during the assessment. Document the reasons why you chose to provide the care that you did. And document the response of your patient to your treatment. Remember, clear documentation is necessary just not for the emergency department, but when the patient is released and sees a private physician or is admitted to the hospital, and your chart will be reviewed by the nurses and on the floor to get an idea of how the patient was initially. When performing emergency care, again, if the patient appears to be having a severe allergic or anaphylactic reaction, administer BLS. Make sure you provide ventilatory support and CPR if necessary, and provide prompt transport to the hospital. If the patient was stung by an insect and the stinger is still present, scrape the skin with the edge of a sharp, stiff object such as a credit card. Don't use tweezers or forceps. Remember, especially with the honeybee, the venom sacs will still be attached to the stinger, and if you use tweezers, you may be squeezing venom deeper into the patient's body. Be alert for signs of airway swelling and other signs of anaphylaxis. Consider a nasopharyngeal airway if the patient will tolerate it, earlier instead of later when the patient's having trouble breathing. Place the patient in the supine position and give oxygen as needed, and monitor the patient's vital signs. Epinephrine rapidly reverses the effect of anaphylaxis. It mimics the sympathetic nervous system response, the fight or flight response. It's normally prescribed by a physician to a patient that has known allergic reactions. It comes in a pre-dosed syringe as an auto-injector, better known as the EpiPen. In our local protocols and throughout the state of Washington, EpiPens are a normal part of EMT equipment. This may be either carried in an EpiPen, the auto-injector, or EMTs may have to draw it up out of a vial in order to give it. In this course, we'll teach you both ways. Whether in an auto-injector or drawn up out of a vial, there are two different doses for epinephrine. For the adult or child over 60 pounds, the dose is 0.3 milligrams. For an infant or a child up to 60 pounds, the dose is 0.15 milligrams. Epinephrine can have an effect within 1 minute, so it is the primary way to save the life of someone with severe anaphylactic reaction. Epinephrine has effect on the heart and the lungs and the vessels. It makes the heart beat faster and harder. That's the chronotropic and inotropic effect. In the lungs, epinephrine will dilate the bronchioles and allow the patient to get more air in. It'll also cause vasoconstriction, the constricting of the vessels. When we look at this and the effects and side effects of epinephrine, because of the vasoconstriction, we'll see a higher blood pressure. Because of the chronotropic, meaning that it makes the heart beat faster, and the inotropic effects of epinephrine, meaning that it makes the heart beat harder, we'll see, again, high blood pressure and increased pulse rate. You may see some cardiac arrhythmias, some pallor, the patient will get pale because of the vasoconstriction, some dizziness, some chest pain because the heart is beating harder and faster, increasing the myocardial oxygen consumption, headache, again because of the increased blood pressure, nausea, and vomiting. These are all normal effects and side effects of epinephrine. Do not give epinephrine to patients without signs of respiratory compromise or hypotension, and anaphylaxis or allergic reaction, unless directed to by medical control. Also, do not give epinephrine if the patients do not meet the criteria for a diagnosis of anaphylaxis. Let's go ahead and look at this case. You have a patient who's a 45-year-old male. The patient reports being stung several times by bees as he was mowing his lawn. The patient reports that he's been allergic to bees in the past. The patient currently complains of dyspnea, and you notice that he is developing swelling around his eyes. During our scene size up, we asked where he was stung. He was stung in the rear of the house. He was in the front of the house. So the bees are in back. Watch out for bees that might have followed him up. Also, be careful of bees as you're removing the patient's clothing. Sometimes bees can be hiding in shirts, in pants pockets, in cuffs, shirt pockets. Be real careful of that. That's mainly your safety considerations. So let's consider our sample history. Again, he has signs and symptoms with dyspnea, shortness of breath, periorbital swelling, swelling around the eyes. He does have a past history of allergies to bee stings, and you're counting about 5 of them. His medications is only one, benazepril for his high blood pressure. He ate 2 hours prior his breakfast. This happened probably late morning. And the events leading up to the call 911 was, of course, the recent bee stings. When we perform our physical exam, of course, we first have the general impression this patient is having respiratory distress. We can see that. It involves, of course, the pulmonary system. The patient has swelling of the periorbital area. That's swelling around the eyes, as you see here in this picture. That includes the system, that includes the skin. Again, we have now 2 systems that we're concerned about. Vital signs show a BP of 94/62 with a pulse rate of 120. Respiratory rate is 22, decreased volume, and labored. He's using a little bit of his accessory muscles. He's setting 92% on room air, which is below our usual 95%, and he has wheezing on careful consideration of his lung sounds. Now, keep in mind, we always are very wary when a pulse rate is higher than the systolic blood pressure. Something to keep in mind. So now we ask ourselves, what would our treatment be? So, is this patient sick or not sick? Well, he's talking to us, he still has a blood pressure, but even though he's probably not sick now, the possibility of him being sick, dangerously sick, ready to die is right there, ready to happen. So, for all intents and purposes, this patient is in the sick category. When we consider the treatment of this patient, remember, these are bee stings. So the venom sacs are still attached to the stingers. We want to look for the sites as our partner is getting us an EpiPen or drawing up epinephrine, because this patient does need epinephrine. But we look for those bee sting sites and scrape away or scrape out the stingers. Again, we're scraping away, not using squeezing or tweezers that would cause more venom to go inside the body. After we get the stingers, we want to go ahead and give the epinephrine. Epinephrine is given 0.3 cc's, that'd be 0.3 milligrams, of 1 to 1,000 IM. We normally put this in the side of the leg and the thigh area, and we'll be going over how to do that in our skills lab. So we're also going to treat for shock. We're going to make sure the patient's in a proper position, supine or perhaps Trendelenburg. Give the patient oxygen. Remember, his sat oxygen was 92% on room air. So we're going to go ahead and give him some oxygen, 15 liters per minute by non-rebreather. We're going to keep him warm, as that normally is what we do when we treat for shock, and then transport rapidly to the emergency department or rendezvous with ALS. If ALS is nearby, we may want to wait for them. Otherwise, get on the road, start heading towards the hospital. As we perform our reassessment, we want to start with the things we do in our initial assessment. Airway, breathing, circulation. Is the patient getting any better? We want to listen to those lung sounds. Has any of the wheezing that we heard earlier clearing up? Is the patient saying that he's feeling better? And that's really important. Now, if he's not feeling better in this case, after 5 to 10 minutes, we may want to get online with medical control and consider a second dose of epinephrine. Again, this would be based on the patient's age, his past medical history, and what his current vitals are. Before you go and call medical control, make sure that you have a current and second set of vitals. So, for the purposes of this particular case, we're going to say that we've given the patient epinephrine. They've gotten better. We've also got them on oxygen. We got them supine. We got them warm. The patient, after the epinephrine, has improved. His blood pressure has come up, 110 over 68 with a pulse rate of 100. Respiratory rate is better. It's at 22. His wheezing has cleared up a bit. We meet with ALS. They take over patient care. They start a couple IVs. Because he is over 40, they went ahead and put him on an EKG. Remember, epinephrine affects the heart, and the fact that it makes it beat harder and faster, uses up more oxygen, higher myocardial oxygen consumption, that's referred to as. So the patient has been receiving oxygen, but we're going to watch for dysrhythmias that could be caused by that rapid heart rate. And the patient is transported. And the patient, chances are, once again, the hospital will probably be in the hospital for several hours, if not overnight. What we want to do for our documentation is we want to make sure that we go and document what we found, the patient's history, especially that history that indicates that he was having an anaphylactic reaction, including the fact that he's been allergic to bees in the past, he's been stung several times, our physical findings, make sure that is all documented, and what we gave him, how we treated him, and just don't focus on the epinephrine. Make sure that you document the supine positioning, the warming, the oxygen, and how the patient was when he was delivered over to the ALS crew. So that pretty much covers it for immunological emergencies as we look at them on the EMT level. There is a worksheet that is posted. Go ahead and please do that, and we will see how we do for Monday and get some stuff up for the next chapter. And we'll also be having an idea about what we're going to be doing as far as the rest of the course. Thanks for hanging in there with us, and we will be talking to you all later. If you have any questions, email Doug, and he will answer them on the technical level. Or if you need anything else, get a hold of either one of us. Hope you have a good weekend. God bless. Bye-bye.